and hello everyone, and welcome back to the conference. We are looking forward to our next two presentations, which will conclude the program for today. For the first presentation, we will be sticking with the theme of COVID-19 and get a South African insurer's perspective on the impact of COVID-19 on future healthcare utilization. Let me first introduce the presenter, Shirley Colley. Shirley qualified as an actuary in 2009. Her experience includes lecturing in the Department of Actuarial Science at Wits University, supervising actuarial science honors research papers, and contributing to the syllabus of the Actuarial Society of South Africa's Specialist Healthcare Technical Subject. She has extensive analytics experience in healthcare, ranging from clinical claims reporting, alternative reimbursement contracts, construction of provider profiles, and development of clinical classification systems and tools to meaningfully evaluate healthcare expenditure. She currently heads up the Analytic Intelligence Cluster in Discovery Health in her role as Chief of Actuarial Healthcare Analytics, which is responsible for all clinical claims analysis, provider contract measurement, quality measurement, forensic analysis, and operational analysis. In her presentation today, she will be looking at how the COVID-19 disruption continues to impact non-COVID-19 healthcare utilization levels and trends, and the uncertainty whether, if in a post-COVID-19 environment, healthcare utilization will revert to pre-pandemic levels. So let me hand over to Shirley now to take you through her presentation. Thanks, Shirley.
Thanks, Lydia. Let me share my screen. Can you see it, Lydia?
It's coming through now. Just hold on a bit. There you go. I can see it now.
Great. Okay. Good morning, everyone in South Africa, and good afternoon to those of you in Singapore, lucky enough to all be together in person. Let me begin this presentation with just some background to my home country, South Africa, and where the healthcare industry was prior to the start of the COVID-19 pandemic. Okay, so South Africa's healthcare system mirrors its dual economy, which has one of the highest persistent inequality rates in the world. In 2019, Time magazine ran a special feature on South Africa, and on its front page, a picture of rolling green lawns contrasted across the road with densely packed informal settlements. Approximately 8.9 million citizens are members of private healthcare funds, referred to as medical schemes in South Africa, which by law offers a minimum package of prescribed minimum benefits. Membership to a medical scheme is voluntary, and membership to some medical scheme funds are employer-based, while others are open to any individual and any employer. The healthcare delivery system in South Africa is divided between private providers of healthcare funded by medical schemes or out of pocket, and public facilities funded by general taxation. A similar percentage of GDP is spent in both the private and public sector. However, about 5 times more is spent per capita in the private sector. The African National Congress, which is the ruling party in South Africa, has had a policy position of moving towards a national health insurance. It is one of the most ambitious policy reforms of the government. When the National Health Insurance Bill got published, the market did not react favorably given the uncertainty of the role of medical schemes, and the Johannesburg Stock Exchange Index lost more than 6% in the 2 days following the bill's release. The Competition Commission, at the request of the Minister of Health at the time, undertook a healthcare market inquiry to investigate prices in the private healthcare sector. There were numerous submissions and some well-considered recommendations were made that, if implemented appropriately, are believed to make costs in the private healthcare sector more sustainable. However, the political will and state ability to implement has been constrained. And then COVID arrives. South Africans experienced one of the most stringent lockdowns in the world. From the end of March to April 2020, household members were not even allowed to leave their households for exercise outdoors. South Africans continue to experience various levels of lockdown in the last 18 months, dependent on COVID-19 case numbers. The data that I'm sharing with you this morning is based on Discovery Health clients, just over 3.5 million individuals. Discovery Health is a company which offers administration and managed care services to its 18 employer medical schemes, covering 707,000 beneficiaries, and the largest open medical scheme in the country, the Discovery Health Medical Scheme, covering 2.8 million beneficiaries. Discovery Health has rich longitudinal demographic, clinical, and claims data on our clients. 58% of our membership base have been clients for more than 5 years. COVID-19 infections are documented based on COVID-19 PCR pathology results from private laboratories, and COVID-19 admissions were identified from Discovery Health's pre-authorization data for COVID-19 confirmed individuals. This data enables us to report daily on COVID-19 caseloads and outcomes, and helped empower our contracting team to rapidly evaluate healthcare provider proposals in an informed manner and guide relevant managed care interventions and product enhancements. To date, South Africa has experienced 3 waves of infection and 250,000 excess deaths since the start of the pandemic. Since the excess death numbers mirror the COVID-19 infection numbers and rise and fall as the COVID numbers increase and decrease, it is believed that most excess deaths are attributable to COVID-19. If one assumes that 90% of natural excess deaths are COVID-19 related and compares the numbers against the official COVID-19 death toll, one sees that deaths are underreported by a factor of 2.7. When we evaluate excess deaths amongst our own client base relative to reported COVID-19 deaths, the underreporting factor is reduced to 1.7. Deaths were obtained from the South African Medical Research Council's Vitality Register, and deaths were classified as COVID-19 related if a natural death occurred within 14 days of a discharge for COVID-19 admission, the death occurred in hospital when admitted for COVID-19, or a natural death occurred within 28 days of a positive PCR test result. It's not surprising that the extent of underreporting of the privately insured population in South Africa is less than that of the country as a whole, given healthcare access and equity differences. However, given that even deaths are underreported for the privately insured, it shows that not all individuals are testing or seeking care despite having access. One of the simple digital innovations deployed by us at Discovery Health at the start of the pandemic was distribution of a pulse oximeter once we were aware of any of our high-risk clients testing positive for COVID-19 through our integrated pathology data repository. High-risk members were identified using a machine learning predictive model for high risk of a respiratory admission, because at the time we just simply had no historic data to estimate COVID-19 risk specifically. Together with consideration of the WHO documented clinical categories deemed as high risk for severe COVID-19 outcomes. A consultant would reach out to a high-risk member telephonically to dispatch a pulse oximeter. At the time of launching this benefit, a very small percentage of the population knew about the importance of monitoring oxygen levels in the out-of-hospital setting. When evaluating this benefit, we found a pleasing result, almost a 50% reduction in mortality risk, explained by lower CRP markers on admission. CRP stands for C-reactive protein, which is an inflammatory marker. We evaluated COVID-19 outcomes for the pulse oximetry intervention by using Cox proportional hazard models, as increased time since PCR collection date was associated with decreasing risk of admission and death. So it was important for us to equalize for this between the intervention and control group, as the intervention group on average received a pulse oximeter 3 days after PCR collection date, owing to the lag of results becoming available. These models enabled us to assess the relative risk across demographic and clinical factors. We see that individuals with 3 or more chronic conditions have a 78% higher risk of admission compared to someone with no chronic conditions. And individuals with HIV have a 43% higher admission risk. Increased age is also associated with higher risk of admission and death. And you can see in this diagram, by observing the y-axis between the two charts, that age is the most influential factor when it comes to the demand for hospital services. These models enabled the Discovery Policy Team to contribute insights to the Ministerial Advisory Committee to guide prioritization of the population for our government's mass vaccination campaign, and to understand the trade-offs of an age-based rollout versus a rollout based on clinical conditions. The COVID pandemic is estimated to have generated almost 10 billion rand in additional healthcare expenditure since March 2020 for schemes under Discovery Health's administration. This represents 6% of risk expenditure in 2020 and 17% of risk expenditure for year-to-date July 2020-21. The bulk of these costs are due to COVID-related admissions, which constitute 74% of these costs, and PCR testing constitutes 17% of these costs. Utilization trends were upended by the pandemic. Our second and third wave of infections resulted in much higher in-hospital caseloads. In spite of this, overall hospitalization utilization, even during peaks of COVID-19 caseloads, remained well below utilization levels prior COVID-19. And out-of-hospital utilization levels have also, for the most part, since the start of the pandemic, remained lower than pre-COVID utilization levels. We did observe some increased utilization post the announcement of South Africa's level 5 lockdown and prior to the actual lockdown in late March 2020, with clients quickly moving to fill chronic scripts and stocking up with over-the-counter medication. The drop in hospital utilization was profound across all clinical categories. Significant reductions in angiograms, diagnostic scopes, tonsillectomies, and adenectomies and spinal procedures. There was also a decline in maternity-related utilization, with many favorable reductions actually increasing maternal quality indicators. So, for example, we observed some reduction in the average length of stay in hospital, a 14% reduction in neonatal admissions, most likely driven by the 14% reduction in pre-38-week gestational births. In terms of out-of-hospital care, we observed a significant increase in pathology expenditure related to COVID-19 screening. We also observed an increase in the favorable trend of a shift from acute settings of care for day procedures to day clinics. However, one of the most concerning trends observed was the significant reduction in preventative and screening care. Throughout the world, healthcare systems have seen an increase in the engagement of digital and telehealth platforms amongst patients and clinicians. Based on our own data, we observed a doubling in the number of consults on our Dr. Connect platform, and many of our clients engaged electronically to book vaccination appointments. So 2020 and 2021 will be outliers for many years and will need to be treated separately for setting future utilization assumptions. But the question is, How long can we expect utilization to remain depressed? And what will it look like in the future? Well, the answer to that question depends on how long the pandemic lasts. We've seen repeatedly that vaccines are effective at reducing the risk of severe COVID-19 outcomes, including hospital admission and mortality risk. Does vaccine hesitancy threaten to take us backwards? I would argue not, as it is not the first time that segments of the population have been adverse to vaccination. There you can see an anti-vaccination campaign from 1902. But despite these small pockets of misinformed individuals, humanity did manage to eradicate the smallpox virus with vaccination. There's also a growing body of thought that the pandemic will last for as long as people to believe it to last. And on the right, you have a picture from the roaring 1920s, when much of society got back to normal, even though infections and deaths from the 1918 influenza pandemic continued, even though at a lower level. Given the extent of vaccination in much of the developed world, it is likely that 2022 is the year of returning to normalcy. There are also the long-term effects of the pandemic to be considered. There on the left, you have a horrific picture from the 1950s of rows of nurses caring for children in iron lungs, which were mechanical respirators to simulate diaphragmatic breathing. Children would spend about 2 weeks in iron lungs and then hopefully recover, but there was a small percentage that continued to depend on iron lungs for much of their lives. And then one of the most common long-term effects of polio was the permanent disability induced by the virus. So the question is, what are the long-term effects for those who survive COVID-19? In our data, we have observed a 1.5 times higher risk of developing a long-term cardiac chronic condition and a 3.5 times higher risk for individuals who are hospitalized with COVID-19. We observe even higher risk of diabetes onset post-COVID-19 infection, a 2.8% higher risk, and almost double the risk for patients who were hospitalized, which is equivalent to 5 times the risk faced by a comparator population with a similar age and gender profile. The long-term effects of COVID-19 and its course is unknown and treatment is evolving. We estimate an additional 5 to 12% in healthcare utilization costs post-recovery in the first 6 months for patients recovered from COVID-19. So how should one think about utilization going forward? This might be a frightening picture to some of you, especially if you are imagining healthcare utilization to increase exponentially like Moore's law. And I would just like to preface the point that I'm about to say is that it is not at all my expectation for healthcare utilization, but rather one for innovations and advancements which will increase healthy human lifespan. Moore's prediction in 1965 was that computing power doubles every 2 years, which has largely stayed true and is why this prediction has been now moved to the title of law. Why I'm showing this picture is it is hard to know when one is at the early phases of advancements, right at the bottom of the curve, to anticipate an exponential increase in discoveries and technologies. But if we think about advances in medicine, it is possible that we may see Moore's law play out in the decades to come, given increased computing power. This implies that there may be a rapid acceleration in discoveries and consequent impact on healthy human lifespan in a relatively short period of time, which will require significant modification of how risk is priced and financial products are designed. This graph on the right shows the number of new FDA approvals by its Center for Drug Evaluations and Research per annum. And one can definitely see a rise in the number of new molecule approvals in recent years, largely driven by genetic research. However, whilst the future is very exciting, we cannot ignore the current politics, philosophy and economics of the societies we operate in. There's a lot of uncertainty when it comes to setting financial assumptions, even in the near term. How long will the current US bull equity market hold? Will the US dollar retain global confidence and stability given the unprecedented quantitative easing by the Fed in response to the pandemic? And what new health and societal changes can we anticipate from climate change? The modern philosopher Yuval Noah Harari, in his book 21 Lessons for the 21st Century, believes that the world is too complicated for any one of us to truly understand and predict what's around the corner. So what do we do and how do we think about the future? Well, for the near term, it's likely that the pandemic becomes endemic and healthcare systems start to return to normal. In the short term, utilization is likely to increase given the backlog in elective care. There's likely to be continued adoption of digital technologies connecting patients and clinicians. The cost of diagnosis, prevention, and treatment of COVID-19 will continue, but at lower levels than observed in the last 2 years. And in the medium term, technology and discoveries likely to extend healthy human lifespan are likely to continue, which initially are likely to be inflationary. And that's it for me. I'm happy to take any questions.
Great. Thank you very much, Shirley, for that presentation. I'd like to remind the audience again also that please you can add your question on the Q&A button at the bottom of the screen. And if there are already questions there, then you can also like a question which would increase its priority so that I will get to them first. So whilst we give a bit of a chance for people to add their questions, I've got a couple of questions of my own. I think starting with the experience that you've shown on the oximeter impact of distributing oximeters and the impact that that has had on reducing mortality. So I just wanted to see if you could perhaps just add a bit of more information on how did you identify the high-risk patients? So who were they? And also, you know, what's the role, or how does it actually impact mortality? How does that work, I guess?
Yeah. So let me first just give some background to that benefit. And we really were inspired by a New York Times article that got published towards the end of April 2020, and it was written by an emergency physician called Richard Leviton. And he wrote an article to explain to his readers what he learned in his experience at a New York hospital, spending 10 days in an emergency room. And he gave this explanation of this concept of silent hypoxia, which is actually almost silent oxygen starvation. So what he found, which was completely unique about this condition, was that patients would present themselves at the emergency room. They would continue with, you know, messaging friends on WhatsApp. They seemed perfectly fine, but when they tested their oxygen levels, their SATs levels, they were at levels where you would typically have to be immediately intubated. They were at 80%, 85%, etc. And the body is almost working harder without even you consciously being aware of it. So breathing a bit more heavily, etc. And what he found was that these patients quickly progressed to actually requiring intubation, going into ICU, etc. And there the outcomes really certainly weren't great when it comes to having to require ventilation. So there, you know, the kind of call to action was that this is something really easy to monitor with a small device called the pulse oximeter, which is relatively inexpensive, and we can stay ahead of this pandemic by monitoring oxygen levels. So once we read that article, we quickly moved to putting together a benefit, working on procuring the devices, putting together an operational team that would reach out to these members, and then also in identifying who these members were. So one component of the identification was based on the clinical categories published by the World Health Organization of who is deemed at risk of severe COVID-19 outcomes. And the other component was around using all the data we have available on our clients and augmenting that, the eligibility criteria for anyone else who we would think would be at high risk of a respiratory medical admission. So there we used all the data related to our clients based on their historical claims information and clinical information based on what conditions they were registered on. And we looked at the target variable there was the risk of a respiratory admission, as well as we looked at the risk for any medical admission. And we did an ensemble of the two models. And then about 4 or 5 months into the rollout of this benefit, we started getting more data on COVID-19 outcomes. We went through our first wave, and then we were able to move more specifically to a machine learning algorithm that looked to predict the risk of COVID-19 outcomes specifically. But having said that, when we back tested COVID-19 outcomes relative to the risk of a respiratory admission, as well as the ensemble of a risk of any medical admission, and that model was very powerful and highly accurate compared to the COVID-19 model specifically. Okay,
thank you. I've got there came a follow-up on that question in the Q&A as well, asking the Discovery utilized any other early intervention tools other than the pulse oximeter?
Sure. I think like most organizations, we quickly had to kind of move to working digitally. So there was a big move in also just keeping employees safe and getting the organization to function and service our 3.5 million clients with most of the workforce working from home. But in terms of other early interventions, we really did understand that we are a significant player in the private healthcare sector. And we looked to be as accommodating and as flexible and as supportive as possible to our healthcare providers. So firstly, when we're talking about the healthcare industry, we operate in a fee-for-service environment. So many clinicians and much of the industry just really kind of lost their ability to earn a living. So we looked to see what we could do there. So there were some exciting initiatives in terms of the funding thing. We were able to secure our first alternative reimbursement model with radiologists, which was very exciting for us. And that was really around, it was towards, I think we finalized that contract towards the end of 2020. And it's still at that point, not towards the end, I think it was the third quarter, there was still a lot of uncertainty around whether or not we will see more waves of COVID-19 or not. No one knew. So it was just around agreeing to a set utilization level that would give some certainty to these providers going forward, as well as provide the benefit to our client schemes of also having certainty when it comes to budgeting for the next financial year, in terms of where we would anticipate utilization to be at. So there we able to pivot quite quickly in terms of providing a contract there. The hospital groups in South Africa are fairly sophisticated. They each employ their own analytic teams. And And there were also a number of hospital groups where we put that sort of contract in place and in position. And then other areas where we moved also quite quickly is around opening up. I mean, the most immediate thing was just opening up funding for teleconsults and virtual consults, and enabling clinicians to consult with their patients digitally at a rate which was, I suppose, meaningful. And then in terms of our own clients, the pandemic caused, it didn't only cause economic hardship for clinicians, but also for our own clients. So we looked to structure a premium relief program for clients that were struggling to pay their contributions. And yeah, so those were a couple of the initiatives that we quickly looked to put in place to support both our clients and healthcare providers.
Sure, thanks for that answer. I see there's a couple of more questions also coming through about the impact of long COVID. And I also made a note here to ask is, the increase in costs that you mentioned sounds quite, I think you mentioned 5 to 12%. So, especially where, in markets or countries where the cost so far has mostly been borne by the government and it's potentially moving into private insurance now. I think, could you maybe elaborate there, on what cost you are expecting? And I think one question also came through to say that, how do you think insurance companies can underwrite long COVID risk to take account of this additional cost that might be coming from long COVID?
Yeah, so I think firstly, in terms of how long we expect these costs to continue post-recovery is a question mark. We're not certain. But certainly what we see in terms of healthcare utilization for individuals who have recovered from COVID-19 is an increased level of utilization relative to a clinical comparator or a clinical twin. So that's the first thing. We're not certain how long it'll last. Secondly, long COVID is typically described in the literature as symptomatic. In other words, continued exhaustion or heart palpitations or a range of other symptoms. We don't have symptomatic data available. We're about to administer a survey with support from the NICD here in South Africa to start obtaining that symptomatic data and linking it with this financial data to understand, are the two related? So we can better understand how to design, our products to be relevant and meaningful to this population segment. Around the question of underwriting, that's a very good question and a big question. I think to the extent that long COVID symptoms end up causing other conditions that get diagnosed, diabetes, ischemic heart disease, other diagnosed conditions. These conditions are typically already underwritten by insurers. You are required to disclose it. So one might argue then the insurer only faces a risk if these complications from COVID-19 have not yet been diagnosed. And we don't see evidence of that, in the sense that there's a question mark if these higher rates of diabetic complications and cardiac complications are in fact a function of the fact that these patients already had this underlying pathology, and the fact that they were just interacting with the healthcare system, it got diagnosed earlier, or in fact COVID-19 progressed these outcomes. But I do think a lot of the underwriting processes that many insurers have implicitly cover a lot of the complications that we're seeing post COVID-19. I suppose the only other thing to think about is income protection products and how that plays out. Yeah.
Okay, thanks. So sticking also to, staying on the topic of the long COVID risk, just one more question. Is there any evidence or research showing the long COVID risk of cancer?
I haven't seen anything yet on that. So no, I haven't seen anything in terms of the literature being published, or any literature published on that. And we certainly haven't, it hasn't come to us yet from the data explicitly. But to be perfectly honest, we haven't looked at that yet.
Okay, so if I understand correctly, then your assumptions and your conclusions, that was based on, so that was like diabetic, and that's the high risk population with comorbidities already then, or comorbidities.
For long COVID, our analysis is based on the full population, and we provide a range just because there are different approaches in matching the COVID population to the non-COVID population. So in one iteration, we looked at matching to anyone who hasn't had COVID-19 and matching the infected individual with someone who doesn't have COVID-19 based on consistent demographic and clinical features, and we look at their outcomes going forward. And the other approach is matching it to individuals who test negative for COVID-19 to adjust for that healthcare seeking behavior. So that's why we had that range, because we believe the figure lies anywhere in that range.
Okay, thanks. So maybe one more question from my side then, because so long COVID is the one increased cost that you mentioned, and then the other one is of course the backlog in cases. And I think, you know, we've seen the stats from the NHS, for example. Earlier this year, they said that the individuals waiting for elective surgery has gone up to around 10 million compared to 4 million prior to the pandemic. I think it's really interesting what you mentioned with the provider contracting, and, you know, thinking ahead and planning for that utilization. Could you maybe just, are there any other, or have you done the analysis to see what the potential impact might be? And is there any other kind of management strategies that you've employed to manage the potential pent-up demand that might arise going forward?
Yeah, I mean, there is a lot of uncertainty in terms of how much of the backlog do we expect to kind of push through the healthcare system, because most clinical conditions are acute by nature and self-limiting. So if you've managed to cope without an intervention over a period of time, it's not necessarily the case that some of these conditions will require intervention later. So for example, tonsillectomies, even potentially angiograms, etc. So these things typically would have been done over an acute window or requirement. In terms of what, you know, how we're thinking about this risk is, firstly, obviously, is to make sure that in terms of cost per unit, we kind of fairly mature in contracting as best as possible to have as much certainty as possible there. And then in terms of the utilization component, what we really are pushing hard towards is around reimbursing for value, so value-based care. And the reality is that is a long-term journey for us to walk along. And when we're talking about value-based care, you're ultimately reimbursing based on a clinical outcome, not how much of something, not how much gets done and how much utilization is actually incurred. So that's really the intent. And I think the pandemic and the extremity of the pandemic has shown actually, even in the current pandemic, the importance of and the value both to insurers and funders and members and clinicians of reimbursing for value. And in fact, if you are reimbursing for value, in some ways things are a lot less disruptive, particularly when there's stresses to the healthcare system. So yeah, don't know, Lydia, if that answers your question, if that helps make the crystal ball clearer for you.
Yeah, no, but I mean, I agree. It's very unclear. So I guess, I mean, you can manage what you know, and prepare for the unknowns as much as possible. So I think there's just one last question. Just I think coming back to the long COVID question. So just I think the question relates to how you came to the conclusions of the impact of long COVID. So, for example, the risk of diabetes is higher than for a non-COVID person. How did you do that analysis?
Yeah, so all of that is based on matching. So matching against, it's you know, epidemiologists typically refer to it as propensity matching. So it's really around matching someone who had COVID-19 and finding someone else in the healthcare, in our client base who hasn't had COVID-19, who looks as similar as possible to this individual, and comparing it going forward. And this is actually the approach that is done for much of the real world vaccine effectiveness studies that are currently being done and published and being reported on. It's really around comparing the outcomes for people who are impacted by the condition and comparing it against another population that looks similar, and to try and do it in a way that is as least biased as possible. So matching as closely as possible, and it depends on the actual study, but you may go as far as matching on residential suburb area, age, gender, chronic factors related to prior healthcare utilization, even output from other models that you may have, so risk of admission, all of those sorts of features can be used. And the reason why it's important to match as best as possible is you want to emulate a study that enables you to assume a causative impact. So if you have any bias in your matching, you can't be certain that the outcomes you're evaluating in the post period are actually due to the infection. So that was the approach we've applied, and it's an approach that is very consistent. So we've been busy at the moment working in South Africa with the Sisonke research team, and this was a real world vaccine effectiveness study for our healthcare workers in South Africa. So prior to the start of the mass vaccination campaign, 500,000 healthcare workers in South Africa were vaccinated under this Sisonke research program with the Johnson & Johnson Ad26 vaccine. And we've been evaluating the outcomes for this vaccine using a similar approach, which is really around propensity matching, comparing people who got the vaccine against people who didn't get the vaccine, and then looking post in terms of outcomes, whatever your outcome of interest is. It may be admission, it may be death, it may be cost. So you can really look to evaluate a range of different outcomes.
Okay, thank you. And thank you, thank you for, I think that's all the questions answered then. Thank you for providing that very detailed answers, and thank you for a very interesting presentation as well. So I think what we would do now is we will go to the poll for this question. So if I can ask the attendees to please answer the poll before we go onto the next section or session. Thank you, Shirley.
Thanks very much, Lydia.